I want to talk today about the combination of CAD and heart failure. Should we revascularize and what workup should we do? Should everybody with heart failure and reduced EF undergo coronary angiography? I will start by defining ischemic cardiomyopathy. And before that, there are five major causes of LV systolic dysfunction and cardiomyopathies in my classification. You have the CAD, which causes 60% of heart failure with reduced EF in modern heart failure trial. You have hypertensive cardiomyopathy, arrhythmia-induced cardiomyopathy, whether AFib, tachyarrhythmia, frequent PVC, or conduction disease, progressive left bundle branch block, or RV pacing. Then you have residual effects of advanced left valvular disease that gets corrected late at a stage when LV dysfunction may not correct postoperatively. And that LV dysfunction is more often intrinsic and irreversible in the case of the volume overload states of MR, and less so AI, and least so AS. That's one reason why the surgical EF cutoff is 60% in severe MR versus 55% in AI and 50% in AS. Then you have the fifth type of cardiomyopathy is the dilated cardiomyopathy after you've ruled out the top four, and that could be genetic, idiopathic post-myocarditis, toxic, peripartum. And there is an entity close to dilated cardiomyopathy that is recently defined called non-dilated LV cardiomyopathy, which is like an early stage of dilated cardiomyopathy where the LV is not dilated and EF may or may not be reduced. You may only have just some scarring on MRI. Now, how do you define specifically ischemic cardiomyopathy? It's LV systolic dysfunction that is secondary to CAD. And how do you attribute cardiomyopathy to CAD? There are two overlapping processes that can cause ischemic cardiomyopathy. One, large transmural Q wave necrotic MI, and two, a hibernating, mostly non-necrotic myocardium. And you may have again overlap and a mixture of both those processes, number one and number two. And hibernating myocardium means you have severe coronary stenosis that causes chronic ischemia at rest or recurrent exertional ischemia and causes the myocardium to shut itself down without dying. And hypothetically, that can be reversed with revascularization. So when do we attribute cardiomyopathy to CAD? Based on a clinical trial definition as defined in 2002, you need to have one of the following three: history of large MI or more than two vessel CAD with 75 stenosis at least in each, or single vessel CAD that involves the left main or the proximal LAD. The more extensive the CAD, the more you have an increase in mortality. And some patients have mixed cardiomyopathy, such as LV dysfunction secondary to two vessel CAD and aggravated by hypertension or AFib or left bundle branch block. So why is it important to distinguish ischemic from non-ischemic cardiomyopathy? One, because of worse prognosis with ischemic cardiomyopathy. It's 1.5 to 2 times higher mortality than the average non-ischemic cardiomyopathy. Number two, the possible benefit of revascularization. Hence, the frequent need for coronary angiography in most patients with LV systolic dysfunction without a clear cause such as hypertension or arrhythmia, although the need for that angiography has been tempered by latest data, and I will detail those. And this is from that paper in 2002 that defined ischemic cardiomyopathy and showed the difference in mortality between non-ischemic and ischemic cardiomyopathy. And that paper showed that one vessel disease has the same mortality as no significant CAD. And that's why we require more than two vessel CAD to define ischemic cardiomyopathy, or single vessel that is left main or proximal LAD. If you have LV dysfunction with one vessel angiographic CAD, not left main or proximal LAD, and without evidence of a prior large Q wave MI, This is LV dysfunction disproportionate to CAD and implies a mortality similar to non-ischemic cardiomyopathy. This LV dysfunction is better classified as non-ischemic cardiomyopathy with incidental CAD. Ischemic cardiomyopathy is defined typically by coronary angiography, but there are hints to it non-invasively, such as EKG. Whenever you look at an EKG of a heart failure patient, Q waves are the single most important feature you should look for. Q waves are seen in 70% of ischemic cardiomyopathy, so you may have ischemic cardiomyopathy without Q waves, and Q waves do not mean irreversible dysfunction. They may be seen in a hibernating myocardium. They do reduce the likelihood of myocardial recovery and viability, but they do not exclude it. And most patients with Q wave experience some improvement of LV function with medical therapy or other therapies and revascularization. We also look for other abnormalities on the EKG that could gear us toward other cardiomyopathies, such as AFib, frequent PVCs, or conduction disease, left bundle branch block with QRS more than 130, which suggests left bundle branch block aggravated cardiomyopathy. Other EKG findings have prognostic value but are not specific for an etiology, such as LVH with STT strain. The more pronounced the STT abnormality and the wider the QRS, the more likely the patient has lower EF and the worse the prognosis. Also, that association that I explained in the past of a large QRS voltage in the precordial leads with a relatively low QRS voltage, less than 8 millimeter in the limb leads, suggests dilated LV with low EF. Segmental all motion abnormalities on echo suggest ischemic and cardiomyopathy, but this is not sensitive nor specific. Some non-ischemic cardiomyopathies may have segmental motion abnormalities, such as myocarditis or postmyocarditis, which tends to predominate in the inferior and inferolateral walls, or sarcoidosis, which also predominates at the inferobasal inferolateral wall, as well as any dilated cardiomyopathy with focal segmental scarring. I will describe a little later a role for cardiac MRI, and I will describe the role of coronary angiography in our modern era. It's still reasonable to do coronary angiography in all heart failure with reduced EF, but its value is tempered by the limited value of revascularization. It has grossly two values: a prognostic value, classification of the cardiomyopathy, and specific subsets may benefit from revascularization. But I will detail that a little later. Now, let me discuss coronary revascularization in ischemic cardiomyopathy. And here there are two major trials that you need to know very well. STICH, which studied CABG in ischemic cardiomyopathy, and Revived BCIS2, which studied PCI in ischemic cardiomyopathy. STICH trial, published in 2011, took patients with ischemic cardiomyopathy F less than 35%, and the median was 27%, and they were randomized to revascularization with CABG versus medical therapy. Most patients had 3-vessel CAD, 60% of them, and they often had proximal LAD stenosis more than 75%. 70% of the patient had that. And most of them had a prior history of MI. The age was 60, younger than the PCI trial Revived, which was about 70. Patients were not excluded based on viability testing. The trial did exclude severe angina, and it consisted mainly of patients with severe LV dysfunction, moderate heart failure, class 2 to 3 for the most part, a very small proportion of class 4, and no or mild angina. And you see here 3% of patients had class 4 heart failure. At 5 years, CABG was associated with a strong trend towards mortality reduction, but by less than 1% per year. 8% per year mortality in the medical arm versus 7+ mortality in the CABG arm, which was not significant at 5 years. It became significant at 10 years, again, less than 1% mortality reduction per year, and there was a significant reduction of heart failure hospitalization. So CABG did provide some benefit in ischemic cardiomyopathy, but it was only a late and marginal benefit versus medical therapy. CABG mortality benefit did not become significant until 5 to 10 years of follow-up, and the mortality reduction was mild, only 7% at 10 years and 10% at both 5 and 10 years in the as treated analysis and in the higher risk group. So if you spin the data to the high risk patient or the patient who were treated as planned with CABG, the mortality reduction was still not dramatic, 10% at 10 years, about 1% per year. And there wasn't much crossover in the medical therapy arm to attenuate the perceived benefit from CABG. There was only about 11% crossover to CABG in the first year and only 20% at 10 years. All this implies that CABG is reasonable but not urgent in patients with ischemic cardiomyopathy, although it is given a class 1 recommendation in both the ESC and ACC CAD revascularization guidelines. On subgroup analysis of STICH, the benefit was more pronounced in two big groups: those who had 3 vessel rather than 2 vessel CAD, along with the lowest EF, less than 27%. Those had around 10% mortality reduction at 5 years and at 10 years. And the benefit was also more pronounced in young patients less than 55 years old. So those two groups should more readily be offered CABG. Again, the benefit was still not dramatic, even in those groups. And there is always a question mark. Would sicker patients, those with recurrent heart failure hospitalization or class 4 heart failure, benefit more? Would that benefit extend and get magnified in sicker patients with more advanced clinical HF? Keep in mind that those patients have higher surgical risk, therefore a higher risk of harm, and may not live long enough to derive that late CABG benefit at 5 to 10 years later. And the same way sicker patients derive an amplified benefit from good therapies, they may also succumb to an amplified harm from non-useful therapies. So it's not clear that sicker patient will benefit more. Now I will discuss the revived BCIS-2 trial published in 2022, and this trial compared PCI to medical therapy in ischemic cardiomyopathy. They took patients with the F less than 35%, median 27%, like STICH, and they took patients with a stable CAD supplying a large amount of myocardial territory. It has to supply at least over 50% of the myocardium, and in most patients, that CAD was supplying more than 2/3 of the myocardium. So stenosis were mostly proximal, and they mandated stenosis to be more than 50% for the left main and more than 70% for non-left main vessels. Most patients had mild heart failure. 23% of patients had more advanced heart failure, class 3-4 NYHA. And they took mainly patients with proximal 2 and 3 vessel CAD. 38% had 3 vessel CAD. And even left main disease was included. That's one of the very rare CAD trials that included left main disease. STICH trial excluded left main disease. All classic chronic CAD trials excluded left main, such as ischemia trial, courage trial, Barry 2D trial. And they mandated viability on viability testing, unlike STICH, which took patients with and without viability, and the age was older, 70 plus or minus 9. And the surprising result was that after a mean follow-up of 3.5 years, PCI did not improve any outcome compared to medical therapy. Death and MI were similar, and death was quite high. Even EF improved similarly with PCI versus medical therapy by about 5%. Most patients had no angina or mild angina. Heart failure was mostly compensated, as I mentioned. And patients with recent large acute MI in the last 4 weeks were excluded, as in the STICH trial. And keep in mind that in Revived, as in STICH trial, although there was a limited number of NYHA class 4 patients, recent acutely decompensated heart failure was not excluded from those trials. They only excluded recent shock less than 3 days. Yet the population was overwhelmingly stable heart failure with limited proportion of NYHA4. But those who tell you that Revived and STICH excluded acutely decompensated heart failure, they are not correct. if you look at the inclusion criteria, recent acutely decompensated heart failure was not excluded. Only recent shock, less than 3 days, or severe decompensated heart failure requiring intubation, less than 3 days, was excluded. So why did PCI fail in ischemic cardiomyopathy with a stable CAD in Revive trial? There are several hypotheses. Number one, PCI is inferior to CABG in patients with severe multivessel disease, yet even CABG only provided a marginal and late benefit in STICH trial of ischemic cardiomyopathy. So that first hypothesis does not explain it fully. And the second hypothesis is that revascularization is less beneficial in older patients with LV dysfunction, and Revive took relatively older patient than STICH. And we know in STICH, most of the benefit was on those patients less than 55, 60 years old. And the third and most important hypothesis, in my opinion, that is not much talked about is that once advanced myocardial disease occurs from CAD, the progression of myocardial disease and of clinical heart failure and mortality become less dependent on CAD and the epicardial coronary mechanics and obstruction, and they become rather subject to myocardial mechanics and loading and electrical conditions. In fact, in Revive trial, most of the follow-up events were death, likely from pump failure rather than MI. We had 32% death at 3.5 years and 10% MI. A similar phenomenon was seen in STICH. Look here, at 10 years, you had 59, 66% death, while acute MI was only 6 to 9% at 10 years. So again, that myocardial progression is dictated by loading condition and electrical conditions much more than CAD progression at this stage. And this is evidenced by the relatively low rate of MI on follow-up compared to heart failure hospitalization and pump failure death. Hence, PCI was of no benefit in Revived, and CABG was of limited and late benefit in STICH. And very importantly, people don't remember that even statins were of no benefit in the Corona trial of ischemic cardiomyopathy. This study of rosuvastatin in systolic heart failure, published in 2007, showed that even statins did not reduce mortality in ischemic cardiomyopathy. Wherever you throw statin, they improve outcomes. Yet somehow they did not improve outcomes in ischemic cardiomyopathy. And the main reason for that is that most follow-up events were not MI, they were death. And you can see here that fatal MI was a lot less common than sudden death or worsening heart failure. Conversely, in ischemic cardiomyopathy, myocardial pharmacology is of great benefit, far superior to the benefit from CAD revascularization. Each one of the 4 pillars of heart failure with reduced EF provides faster and more pronounced yearly mortality reduction than CABG did in the STICH trial. You get about 2% absolute mortality reduction for each one of the 4 heart failure pillars per year versus maximum 1% for CABG. Also, procedures that directly affect myocardial mechanics and loading conditions and electrical conditions like biventricular pacing in left bundle branch block, AFib ablation in heart failure with AFib, and mitral valve therapy in patients with severe refractory functional MR appear to reduce mortality much more dramatically than revascularization in the proper context. And look here, in Castle AFib, AFib ablation reduced mortality from 25 to 13% at 3 years, 12% at 3 years. In COAPT, MitraClip reduced mortality from 46 to 29% at 2 years. So pharmacology and therapies for loading conditions and for electrical issues are far more effective than revascularization at this stage of the myocardial disease. And the fourth and important hypothesis is that revascularization of stable CAD with or without LV dysfunction only improves angina, not hard outcomes. And this has been shown in the stable CAD with normal LVEF, such as Courage and Ischemia trials, and now it's getting shown in stable CAD with reduced EF. A fifth hypothesis is that some patients with CAD, including multivessel CAD, rather have non-ischemic cardiomyopathy process that would be shown by MRI, and the CAD is rather incidental in those patients. For example, they may have hypertension or AFib or left bundle branch induced cardiomyopathy or genetic cardiomyopathy, and revascularization is unlikely to benefit those patients. Sixth hypothesis, which is possible and which is the only hypothesis that still lends support for revascularization in a subset of patients, that hypothesis would state that Revive did not provide angiographic stenosis severity. It mandated stenosis more than 70%, subtending in total more than half of the myocardium. But maybe stenosis that are more than 90% are more likely to benefit than those 70 to 80%. This has not been provided yet by the revived analysis. So it's possible that select patients with critical left main or more than 90% multivessel proximal disease derive the benefit from PCI. And regarding that fifth idea, some patients with even multivessel CAD have a non-ischemic cardiomyopathy. And that's why in the current era, classification of cardiomyopathy is better done via MRI rather than coronary angiography. And this was shown in this study clearly. Some patients with cardiomyopathy and CAD, including multivessel CAD, rather have non-ischemic or dual cardiomyopathy. 20% of them in this Minnesota study and 12% of those screened for the revived study. Patients with extensive CAD who also have a non-ischemic or dual cardiomyopathy by MRI have the worst prognosis, likely because of the dual processes, and are unlikely to benefit from revascularization. And on MRI, how do we define the non-ischemic component of the cardiomyopathy? The first way is the LGE, late gadolinium enhancement pattern, if it is subepicardial or mid-myocardial, or if it is subendocardial but not in a coronary artery distribution. The other way of defining non-ischemic pattern is by LV morphological features, such as having severe LVH or severe LV dilatation outside the LGE zone. Without CAD, that could account for hibernating myocardium. Despite those limitations of STICH trial, both the ACC revascularization guidelines and the ESC revascularization guidelines give a class 1 recommendation for revascularization of stable CAD with the F less than 35%. So it's fine to do that, just understand all the pitfalls and the shortcomings I just described. And here is a summary and bottom line. What are the indications for revascularization in ischemic LV dysfunction? Global revascularization with CABG provides mild and late benefit in chronic ischemic cardiomyopathy regardless of viability and of eventual EF improvement, while PCI revascularization does not appear to be beneficial even in patients with viability. So when is revascularization definitely needed? Revascularization of chronic CAD in ischemic cardiomyopathy is definitely indicated for lifestyle limiting exertional angina in patients with compensated heart failure. And the key is exertional angina. Beware that in decompensated heart failure, it's hard to assess angina because chest pain may be a manifestation of heart failure rather than true angina. Now, outside angina, revascularization of chronic CAD has limitation and is likely best suited for patients with critical left main or critical proximal multivessel disease more than 90%. The keywords are critical, proximal, and probably 90% disease, especially if also that patient does not have another explanation for his cardiomyopathy or another driver for his cardiomyopathy, such as severe hypertension or persistent AFib, and particularly in younger patients. For example, a patient with a 3-vessel disease more than 90% with the lowest EF or with age less than 55-60, as suggested by STICH trial analysis. And this would apply to CABG, but may also be extended to PCI. A second important idea is that acute revascularization remains certainly useful in the setting of acute large MI causing acute heart failure or shock. And to say that an acute MI is causing acute heart failure rather than heart failure causing some myocardial injury, you need to have typically extensive ST changes or evolving Q waves on the EKG. So typically it's the EKG that will tell you I'm having an acute MI that's causing my heart failure. It's not the heart failure causing troponin rise. Extensive and profound ST depression or ST elevation. This also likely extend to large type 2 MI with marked troponin elevation, for example, troponin T over 3,400 or troponin I over 1,000 to 2,000, which is difficult to distinguish from non-STEMI causing heart failure. And revascularization is performed within a few days of non-STEMI, not urgently, as I've explained in the past, after diuresis and heart failure or shock stabilization, and it's performed emergently in STEMI, but not in the case of a STEMI or Q-wave infarct more than 48 hours old with a persistently occluded culprit artery responsible for the low EF, as in the OAT trial. Now, a third and debatable idea here. It's unclear whether the limitation of revascularization in revived and STICH apply to chronic CAD diagnosed in the setting of acutely decompensated heart failure without type 1 MI or that large type 2 MI marked by massive troponin elevation or especially by extensive and profound ST changes. It's not clear if you have acute heart failure without that large MI whether you would benefit from revascularization. Some would say that this acute heart failure, decompensated heart failure, is sicker than the chronic heart failure that constituted most of the patient in revived and STICH, and they use that as a justification to revascularize patients with acutely decompensated heart failure. But keep in mind that STICH and revive did not exclude recent acutely decompensated heart failure. They only excluded recent shock less than 3 days. And keep in mind that one may argue that sicker patients with more advanced heart failure derived amplified benefit from beneficial therapies such as ACE or beta blocker or Entresto or AFib ablation or CRT, yet they are most harmed from non-beneficial therapy and have more severe myocardial disease, which may be less likely to tolerate revascularization and to benefit from it. In revived, even patients with the most extensive dysfunctional yet viable myocardium did not benefit from PCI. This is based on a revived subgroup analysis. Now, a note regarding viability. Viability today does not have a significant role in determining whether a patient with ischemic cardiomyopathy would benefit from revascularization. This is because viability testing has not proven a useful guide in the chronic cardiomyopathy setting, such as in STICH or REVIVE trials analysis, or in the recent post-MI setting, as in the OAT trial post-hoc analysis. In REVIVE BCIS2 trial, which only revascularized patients displaying LV viability and defined as global viability with more than 4 dysfunctional but viable myocardial segments subtended by diseased coronary artery. They only took those patients, yet the extent of viability, how many more segments were viable but dysfunctional, the extent of viability did not predict the benefit of PCI versus medical therapy. And the same in STICH trial, the presence or absence of viability did not predict the difference between CABG and medical therapy. And the following pitfalls may explain the limited utility of viability testing. One, viability tests have positive and negative predictive values in the range of 65 to 80%, both for regional and global viability. The assessment of the extent of transmural scarring by MRI is more valid, and this has a sensitivity and negative predictive value of 90%, but a positive predictive value of recovery of 60 to 80% depending on the transmural cutoff used. Keep in mind, MRI highly predicts recovery if you have 0% transmural scarring, and it predicts a lack of recovery if you have 100% transmural scarring. But most patients have shades of gray and fall between that 0 to 100%. And this is where MRI becomes less specific regarding recovery. And importantly, keep in mind that regardless of any viability test, 70% of patients with chronic ischemic LV dysfunction have significant improvement in LV function after revascularization or with medical therapy, a number that is not much different than the yield of viability tests. Also, another caveat of viability tests is that the definition is not uniform. In a patient with enteroapical infarction, the regional viability addresses the viability of enteroapical segment to decide whether LAD revascularization is beneficial, but you can also look for global viability instead of regional viability, and global viability addresses whether there are more than 4 dysfunctional segments that are viable. So there are two types of viability definitions, the regional viability and the global viability. The regional viability that looks at improvement of one segment, and the global viability which looks at improvement of the overall LV function by more than 5% with revascularization. The bottom line of viability testing is that it has a limited role in both revived and STICH trial. Viability is not used to decide for or against the overall multivessel revascularization, and it's given a class 2B in the ACC guidelines, and it's not recommended at all in the ESC heart failure guidelines. Now, I do believe it has a limited and narrow role in one instance. Viability testing may be used to guide the specific of regional revascularization, particularly in this case with PCI. For example, you have a patient with a questionable angina, no clear exertional angina. He's having some dyspnea, but that could be his heart failure. Dyspnea is not specific. You want chest pain out of proportion to heart failure with exertion to call it angina, to qualify for revascularization. So take a patient who has questionable angina and CTO of one vessel and Q waves in that territory. Before you jump into doing complex CTO PCI, perform viability to lend you more support for that PCI. Now, in light of the limitation of revascularization in ischemic cardiomyopathy, the obvious question is, should we perform coronary angiography on all patients with cardiomyopathy outside exertional angina? Exertional angina, yes, definitely. Outside exertional angina, and keep in mind, exertional angina is defined as exertional chest pain. Dyspnea is less specific. It has to be exertional chest pain that is out of proportion to the severity of the patient's heart failure. The patient is in compensated heart failure, he's not volume overloaded, yet he's experiencing exertional chest pain. So outside that instance, should we do coronary angiography to all heart failure with reduced EF? It is still reasonable, and you may choose to do that in all the patients, although this is tempered by the limited value of revascularization. Coronary angiography still has a prognostic value and a value of classifying the cardiomyopathy. And as I explained, even outside angina, we believe specific subsets benefit from revascularization, particularly the critical left main or the critical proximal three-vessel disease. So coronary angiography is definitely indicated if you have progressive exertional chest pain that preceded clinical heart failure or that is out of proportion to the severity of heart failure, or if you have EKG feature of old MI such as Q waves, and I mentioned Q waves are the most important EKG feature you need to look for in a patient with cardiomyopathy, or if you have EKG features of acute or subacute MI with ischemic dynamic ST abnormality, certainly then you have MI causing heart failure. Of course, you need to revascularize that patient as part of MI management. Now, if not universally applied, coronary angiography should be at least considered for heart failure without obvious cause that does not improve with medical therapy. Meaning, if you have a cardiomyopathy and low EF and heart failure with AFib or with severe uncontrolled hypertension, you may consider treating those and reassessing the patient. If his EF remains abnormal or his clinical heart failure continues to progress, then consider coronary angiography. And note again that chest pressure is not specific for CAD in patients with decompensated heart failure with obvious volume overload, as it frequently reflects the oppressive feeling of heart failure's dyspnea or the ischemic imbalance of heart failure. Now, as an alternative to coronary angiography, you may perform cardiac CTA. It's a class 2A in the ESC guidelines. And if you do cardiac CTA, know how to interpret it. We're not looking to fully rule out CAD. We're looking to evaluate for proximal disease that could cause heart failure. ESC recommends it for low to intermediate probability, meaning patients without expectation of heavy calcium or disease burden. So it will be good in those patients to use CTA to rule out CAD. Yet, I believe if properly analyzed with a focus on left main and proximal CAD, it may be used in patients with higher CAD probability and higher disease burden and older patients, as long as you focus on the proximal disease that could be a PCI and CABG target in heart failure. And here I will go on a tangent and say the ESC valve guidelines allow the omission of coronary angiography in those old TAVI candidates who typically have a lot of plaque and calcium burden when CTA excludes relevant proximal CAD. And this was shown in the TAVR arena in registry analysis and meta-analysis, and those demonstrated that CTA has a good positive predictive value for proximal severe stenosis. Again, don't aim to rule out all CAD, just know what you're looking for. You're looking for disease that explains cardiomyopathy and even more so disease that can be revascularized. So I think CTA will gain more role in the future, even in higher risk patients. Now, how about other ischemic workup aside from coronary angiography and CTA, such as dobutamine stress echo starting with a low dose that is used for viability and high dose and assessing for that biphasic response, or using stress SPECT. That other ischemic workup is poorly sensitive and specific and difficult to interpret in patients with LV dysfunction less than 40% who have on echo multiple abnormal segments, and it's hard to gauge how much deterioration there is with dobutamine. It's hard to tell whether that deterioration is driven by tethering of a normal segment by an abnormal segment or whether it is a true ischemia. Same also with nuclear SPECT. Defects are common in non-ischemic cardiomyopathy because of patchy scar tissue, even if there is no CAD. On the other hand, up to 30% of patients with multivessel CAD have balanced ischemia without any apparent defect. They may have a normally appearing perfusion on SPECT. And this was shown in the FAME trial analysis and in other analysis. Up to 30% of patients with multivessel CAD have an underwhelming nuclear SPECT. Thus, nuclear testing and stress echo is not sensitive or specific to diagnose CAD as the cause of cardiomyopathy, and those are better avoided. In fact, in a large Danish registry, less than 5% of patients underwent those non-invasive stress tests as assessment for heart failure. And in that large Danish registry, overall, only 20% of heart failure with reduced EF patients underwent ischemic evaluation, mainly coronary angiography. And of those 20%, only 16% underwent revascularization. The numbers were similarly low in a US Medicare and insurance registry. This possibly reflects the proven limitation of CAD revascularization and the reluctance of some clinicians to assess for CAD in cardiomyopathy. Now, regarding guidelines, both the ACC and ESC guidelines are confused and not helpful as it pertains to ischemic workup for cardiomyopathy and what type of ischemic workup to perform. ACC guidelines give a class 2A for ischemic workup without specifying the modality, coronary angiography versus non-invasive test. ESC guidelines give a class 1 for coronary angiography in the case of progressive angina, as I explained it. And I add if you have EKG features of MI. And class 2B, only class 2B for coronary angiography in patients with high CAD probability clinically, such as many risk factor, older age, but they only give that a class 2B. They give class 2A for coronary CTA in low to intermediate CAD probability and class 2B for non-invasive stress test. So again, they are kind of confusing, but what stands out is class 1 for coronary angio in the case of progressive angina, or of course EKG features of MI, and consider CTA as an alternative in low to intermediate probability, and probably, like I explained, in higher probability if you know how to interpret it.